short fellow, and I'd like to thank Nick for stepping in at quite late notice to give his talks. It's normally talks that he gives to the foundation year doctors, so slightly adapted. This lecture came about. I understand you guys have got lots of kind of ad hoc extra lectures, just filling the gaps. You kind of have this panic towards exams, and you don't really get much orthopedic teaching at all. This came from the ATLS teaching, when even then one of the lecturers didn't turn up, and unfortunately you missed the vital one before my one, so it didn't completely make sense. But from that I realised actually there's this huge unmet need of not having really much orthopedic teaching. It's difficult, only today, and maybe one more session that we can do another afternoon, to fit a huge amount in, but it's just going through those kind of high value topics and orthopedic emergencies is useful to know. Clinical examination is a very difficult thing to teach in elective theatre, and I had thought it was going to be about 20 or 30 people, and we were going to get a few of us and break up into groups of 6 to 8 people. That's clearly not going to happen. So we'll go through a few things. I'll try and point out some just go through the basic approach to orthopedic examination in general, a few special tests, and just a few techniques to make yourself look slick, do it quickly, and then get out of the way. So as long as you practice it, you do it quickly, you just don't think about the examination, you're thinking about whatever commentary you're going to give or whatever answer you're going to give. And so I've been a member on Twitter since 2011. I sent my first tweet yesterday. My boss told me to do it. So that's why there were these 2 hashtags. The only reason I did it is because the URL is a bit weird. So if you just hashtag Ortho feedback, you get this URL, and it'd be grateful for the feedback, because you just kind of want to know what, Comments are welcomed, not on Twitter though. Just put it on keep it on feedback. And the textbook was it's a huge, great tome of orthopedics. But when I googled myself, as you do sometimes, it came up with this book, and it came up with a whole chapter that you can read on Google Books. So it's worth a look. It's probably a little bit high level, and I didn't write all of the upper limb stuff, so I'm not particularly happy with that. But all the lower limb stuff, which is more or less like you're going to see in your exams anyway, is from this one. So the basic format of every single orthopedic examination, doesn't matter if you know what you're doing, you don't know what you're doing, suddenly you've got this person who's got this crazy looking massive foot and you think, I don't know what to do. You just stick to the principles and you start off by introducing yourself to the patient. So the thing where you're going to fall down, you're going to get marked down, is if the patient, and you may have patients, you may have actors, I'm not sure. Is it actors? They're going to mark you in the same way. So they're going to say how they felt and how they felt, did they feel confident in you examining them. So you're not likely to cause them pain because they're actors and they don't actually have pathology. But if you do cause them pain, and there's nothing even wrong with them, that's definitely a bad thing. But they will also simulate the pain as well. Okay, so if you get a patient with a hip pain or a knee pain or something and you just push it too far and you're not concentrating and watching them, that's bad. So be nice to the patient, introduce yourself, practice your introduction. So when you walk in there, I teach an MRCS revision course and an FRCS clinical examination course. And the stuff that people come out with when they walk in, because they're not thinking about that, they're thinking about something else. And they come up with something really random. Sometimes they'll make up a different name. Or they'll say, oh, I'm one of the A&E doctors. And I'm thinking, well, why did you say that? There's just no reason. You can be in the exam. So, it's my name's Henry, I'm a candidate in the exam. Do you mind if I examined your knee? Or just practice it. And then look, feel, move, special tests, and then have a really nice, snappy closing statement as well. Which again, people manage to balls up amazing, because it's just 3 marks. It makes you sound like you know what you're doing, makes it out as if you've kind of thought about it, as if you've been to a clinic and examined lots of orthopedic patients, which you haven't, but it kind of gives that impression you've got a general approach to it. So, for the hip, and the one thing with this is it doesn't have the presenter view, so I can't see on the next slide. So first thing, what do? Hip examination. Introduce yourself. Good. So if you take that away, this is learn something. And pain. So before you start, you ask if they're in pain, and you ask if they can stand without help. And if they can't, make them stand. What else are you going to look out for before you've asked them to stand unaided? The word unaided is a click. Aids. So, walking stick, shoes with built up or heel raise. If they've got, sometimes people, and they might leave these props obviously, they might have one of those great big long shoe horns because they can't flush the hip to get the shoe. And then ask the person to stand. So where that feedback's coming from. So with them standing, what do you want to know? Make sure they're exposed adequately, so depending on what you're examining. Look for scars. No, it's not. I don't know what it is. Where's the little one? This thing? This is whatever. So you look for scars, and so the scars that you're going to see are anteriorly, possibly, as a young patient if they've had an operation when they were 5. Most of the scars are going to be laterally. They'll have had some sort of lateral approach to the hip, or a posterior scar, which is generally curved, or a posterior approach to the hip. You might have a huge extensile scar, and you don't know what that's from. It could be from anything. It could be from multiple revision surgeries, it could be from a pelvic fracture, whatever. Just comment. And again, we've mentioned walking aids, footwear, etc. While they're standing, you want to assess leg length discrepancy. So leg length discrepancy is a big part of your hip examination, and also spine examination as well, because you can get a functional scoliosis from a leg length discrepancy. So you can comment on the scoliosis, which you can see, which is so this scoliosis is generally an S-shaped curve of the spine in the what's the word? Run on the plane. What's the word? And then look for pelvic obliquity as well. So you can see obviously someone standing with their 2 feet flat on the floor, their knees aren't bent, and their pelvis isn't low. So then, how can you further assess that? You get them to walk, you just ask them to take a few steps. And you have a little room. You're probably going to be in a cubicle. Take a few steps back, and probably, if it's a hip patient, you're going to see a Trendelenburg gait, or possibly an abtalgic gait. The most likely thing is you're going to see a Trendelenburg gait. And all that means is that on one side, you have weak, what muscles? Abductors. That's what it means. That's just what it is. And the reason you've got weak abductors can be varied. So if you've just got pain in your hip, you don't use it, you get weak abductors. And then you do Trendelenburg test. So all of this is while the patient's standing up. So you have a look at them, you look for scars. There's nothing really to feel at this point. And then you do the gait, and then you do a Trendelenburg test. And Trendelenburg test, volunteer. Volunteer from the audience? Just go stand here. Thank you very much. Okay, so there's a few different ways of doing it. And you'll be told maybe different ways, and they'll tell you that this is the only way you can do it. But it sort of depends on the patient, how much support you think they might need, or if they do it, it's not like they're going to fall over, in which case, take a little care. What I'll do with my hands, I'll just ask you, just place your hand, and then just stand on one leg. And what am I going to feel? She's got, what am I going to feel? You learn that the sound side sags, but that doesn't happen. Because if you let your good side sag, that means you're letting your bad side, so we'll see how long you can keep it up. So delayed Trendelenburg tests. You're not going to have to. Either will be positive or negative straight. And so you do it to me, so I'm going to do the patient. And if I've got a weak left hip abductor and I'm standing on my left hip, what am I going to do? So you would say, so you learn that the sound side sags and you go like that. But actually, it's just causing your hip more pain. It's just making it more painful. You're increasing the joint reaction force, it's going to make it more painful. So what they do is, and the reason you've got your hands there, is they use the other hand, contralateral hand, to push up. So you'll start feeling pressure in the other hand, because that just takes off pressure off my hip, takes away the joint reaction force, takes the pressure off my weak abductors. And I leave this hand. It's just this hand. That makes sense? And the reason that is because you've got a painful hip. It's more painful on the left side. I'm not going to let it drop down because the abductors are weak, because it's just going to be more painful. And the reason you walk like that is because you're trying to minimize the pain. So if I want to minimize the pain, and minimize this joint reaction force going through this hip, then we can turn this off. Can you hear me without mic? Yeah. At the back? Sort of. Okay. That's fine. At the back. So, a tie. So this is where I wore a tie. It's not why I wore a tie, but let's just pretend it is. So what you want is you want your centre of gravity to be closest to this hip because it's the most painful thing. The closer your centre of gravity is, the smaller the moments are that are going through that. The smaller the mute off. Mute on. So you want to put your centre of gravity over your hip. Is that, can you now not hear me at all at the back? And by doing that, you're reducing the amount of weight. So if I'm just standing on this leg, we just assume, for argument's sake, that my leg is 1/6 of my body weight, so you've got 5/6 of your body weight, trying to lean around this way. You just take the centre of your body weight as a plank. Hello. Give me a lecture about no one there has heard of Malcolm X. I'll put it back. People leaving, this is not going well. So that was somebody's delivering some human and bovine tendons for me between Imperial and King's, and they turn up there and nobody has heard of this professor. So, think about the tie, you're going to try and get there over that hip, because they're reducing the forces going through that painful hip. So actually, your Trendelenburg gait is not the sound side sagging. So if my left hip is painful, you don't want to do this. Do this, lurch to that side. That's called Trendelenburg lurch, and that's just so you are bringing your centre of gravity, your centre of your body weight, over that painful hip. So you'll lurch to that side. And if you've got painful hip on both sides, you do it both ways. And you might see it. Normally when you walk, your head moves up and down very slightly, but it doesn't really deviate from this plane. And if you look at someone when they've got a Trendelenburg gait, Trendelenburg lurch, the head is waving all over the place. This is really obvious, and it's really inefficient. But still, it's less painful. So it takes more work, it's more inefficient, but it's less painful. So after that, lie the patient down. Measure leg length. True and apparent leg length. First thing you do is you get them there, square the pelvis, so that you're not kind of thrown off by the fact that the pelvis is just a bit oblique. And then when you measure apparent leg length, don't pick the umbilicus because it's not kind of immobile structure. My umbilicus is not where it was when I was 20. It's just not going to be in exactly the same place. So pick a midpoint bony structure, pick the xiphistolum, and to the medial malleolus. And then for true leg length, you measure from the anterior superior iliac spine to the medial malleolus. And then you compare the two sides. And one big tip for finding the ACES, it doesn't matter how big the patient is. You find a nice slim patient, it's very easy. You can just see the ACES. But if you've got a great big fat patient, it's difficult. You might even have an apron of overhanging fat and just nicely padded around, and you just can't see it. It's difficult to kind of feel. Don't do the medical student sort of wandering fingers thing.
you're like, just, yeah, it's there somewhere, and then you take the tape measure and you just measure it from somewhere randomly around it, because you can't feel it. So you take your thumbs, you start below, and you slide up, and you will always find it. There's a guaranteed way to always find an axis. Both thumbs underneath, slide up and feel it, and then you just take the tape measure and stick it under your thumb. Feel light on the couch. Okay, so you don't need to feel too much in the hip. Feel the greater trochanters. If they've got trochanteric bursitis, that's going to be painful. You can't really palpate the hip joint, so don't try. And then the ACEs thing was just talked about. So there's leg length discrepancy. So if you picked up there's a leg length discrepancy, obviously from the patient standing or the patient walking, or when you've lied them down and measured their leg lengths. And there's 5 things you want to consider to work out. You want to know where that leg length discrepancy is. So are they short in the femur, in the tibia? And if they're short in the femur, is it below or above the trochanter? So is it a hip problem, or is it something else? Maybe they've had a previous fracture, which is malunited, which feels short. So the first thing is you make sure the patient's square, the patient's square on the couch. We measure the leg length with that tip, thumbs up. And apparent leg length, and then Galeazzi's test. So Galeazzi's test, anyone heard of it? You might have seen it though. So it's one when the patient is lying down, and you ask them to bring their heels together and knees together. Because you want to work out where the shortening is. So with their heels together, knees together, bring them flat like that. And you look from the side, and you can make a big show of looking at it. Kneel down on one knee, look across, and you want to see where the knees are in comparison. They should line up, because my legs are the same length. Thereabouts. But if your femur is further down here, then the shortening is in the tibia, your knees this way, and it's that way. It's difficult to fake that. That's what it is. So that's called Galeazzi's test, and that's to tell you if the shortening is in the femur or in the tibia. And then let's say it's in the femur, you've got to work out whether it is above or below the trochanter. There's a few different ways of measuring this. But there's a simple one, called the Bryant's test. And it's a modification you can just do with your fingers. What you really should do is get a pen and you mark out the line of where the greater trochanter is. And from the ACEs, it's just a drop of vertical. So you just do it with your thumb fingers. So what you've done before, where you get your thumbs up to the ACEs, same thing on both sides. You're pushing on both sides. Your, get this the right way around. Middle finger goes into the greater trochanter, and your index finger is dropping an imaginary perpendicular down to the floor. And it just depends on if there's any difference between the two. So if you go your hands like this, it feels the same both sides, there's no difference between the two. But if obviously the trochanter is closer to that line you drop down from the ACEs, there's shortening above the level of the trochanter. Does that make sense? Does anybody not understand that? You'd have to try it. This is one of the things where this doesn't work too well in this format. It's better to just show you and then get a couple of you guys to practice it. But that's what he's telling you. He's telling you there's shortening above. And that's normally because you've got an arthritic hip. So that's what it is. So move. What's the first thing you do? So now, before you move the patient's hips, get a range of movement. Yeah, pain with us, so pain's good. Pain is, you definitely want to ask them. And you tell them, if this is painful, you let me know. And I'll stop. You watch their face while you're moving their hips. Yeah, so active hip movements are not that useful, and they can make you look really silly in an exam, because you're trying to get the patient to do quite difficult manoeuvres. And you see this with the MRCS candidates quite a bit. They try and do an active range of hip movement first. You think your range of hip movement is quite a lot, and your leg is heavy, and it can cause problems, especially when when you're asking a patient to hold one leg off the side so you can do adduction and then just roll off the bed. But I've seen that in an exam. So you just, what I would do is start off with straight leg raise. So that's your active test. That's your main active test. Just to see if they've got generally good musculature that they can lift their leg up. You record that, whatever that is, to the bed, and then you can just do a quick scientific stretch test while they're up there. Because they're already up there, it takes 1 second, and it shows you've done a quick screen for a lumbar spine problem. So lumbar spine and hip patients can often cross over. The first thing you do, though, before you start that, I would do Thomas's test. Anyone know that? So Thomas's test is just to make sure you don't have a fixed flexion deformity in either hip before you start recording the range of movement. And you do that by getting the patient. Yeah. You got them lying down on the couch. You got their hips out. It may look like they're fully extended, but actually they can compensate for the lumbar lordosis. They've actually got a fixed flexion. So you slip your hand on the back, bend the knees up to get rid of that lumbar lordosis, and then you can ask them to straighten each leg out at a time. Again, we teach in the lecture theatre, but that shows you if they've got a fixed flexion form. So if you drop their leg down and it doesn't reach back down to the couch, once you've got a flat lumbar spine, they've got a fixed flexion deformity in that hip. And the angle that's off the bed is going to tell you how much fixed flexion deformity they've got, because they can't compensate for it because you're taking their spine up. And the way you do that is by flexing out their other hip. Does that make sense? You've got to practice it. And this straight leg raise plus side stretch test is something I would definitely do. It's really quick. Yeah, so passive. The rest of your examination is passive range of movement. Anyone want to volunteer? Passive range of movement exam? Come, one of the boys. No? Okay. You've got to practice it. It's just to show you the sequence. Because again, you just want to do it in a nice, smooth way. Good man. Okay, might come lie down.
I might break it.
Just lie down in the middle. Not on the side. Don't lie on the side, I think it's one of those folds. So just lie down. I hope. I don't know what the health and safety is about that. Probably lays down straight. So you've got quite tight pants as well. So this might restrict your range of movement a little bit. So first thing, you can just ask them to do the straight leg race. So just within, keep your knees straight, lift your leg up into the air, as high as you can, okay? And then you can just see if you can get any more passively, watching his face. And then just do that and you see, did you get any pain? And did you shoot all the way down to your foot? So if it doesn't, you've just got a bit of tight hamstrings, you've got a bit of tight calf. That's not a positive sciatic stretch test. You've got shooting pain from your back all the way down the back of your leg to your foot. That's a positive stretch test. So, as you hear, we might as well do Thomas's test as well, to make it a little bit more sense. So just rest your arms down each side, that's good. So what I'm going to do, take my hand, doesn't matter which way round, underneath. And then can you bring both your knees up towards your chest, as high as you can, and hold them there. Hold them there with your hands over the top. Okay, so now it's completely flat, I can't take my hand out. And then just drop this leg, keep this one up, drop that one down to the couch. Okay, slightly impeded by his trousers. But if you let him go, he'll probably go straight. So that's another thing, you can't teach people weight. So that's why you come normally wearing shorts. So range of movement, you just want to practice it so that it's a smooth, fluid thing, so that it's quick. So you just say, tell me if you've got any pain and we'll stop. Just put your hands down both sides. And you're going to have the patient lying flat, so kind of semi-reclined. Just one. So we do range of movement, range of flexion, which I can't do because hands are too tight and you have some sort of like. So you go up and then back to 90. And at 90, you probably go to about 130. Back to 90. In 90, holding the knee like this from above, and you're looking down from the top. So you're using his leg as a protractor again. So which way is that? Internal or external?
Internal.
Okay, so it's a mix of answers. because it's sort of counterintuitive because the foot's going the wrong way, but it's internal rotation. Here. And it's pretty tight. So maybe 10 degrees. And then external rotation, about 45 degrees. And it's really easy to measure it because you're looking down from the top. You know that that is halfway between there and there. And also what you expect. So also don't spend too long thinking about it and working out. You pretty much just go with what you expect to find anyway. And it'll be thereabouts. So you've gone up, back to there, internal, external, back down. Hand on the pelvis, either on one, if you're small, put a hand on just the other aces. Put your hand across, put your hand across. Abduction. And you only go as far, you can keep going. You say, well, look, his abduction is massive, but it's not, because his pelvis is moving. So you're fixing his pelvis with this hand. Fix the pelvis, abduction, and then adduction. And you can do this in various clever ways, in silly ways I've seen people do. I wouldn't bother getting the other leg out of the way. You just go across, because you know it's only going to be about 20 degrees. So abduction, 40 degrees, adduction. Okay, and the whole thing is really quick. So you just go up, back down, internal, external, down, out, in, done. So that's your hip examination. Good. Thank you very much. So, active movements, just do the straight leg raise and then movements passive. Maximal flexion, external rotation, internal rotation in 90 degrees, abduction, adduction in neutral. You can also do internal, external rotation there. If you've got a patient with arthritis, you can't get them up to 90 degrees. Try that as well. Right, so closing statement and summary. Does anybody know the standard closing statement? So your summary, you can say, well, I examined this 22-year-old medical student and he had this range of hips and he's pain-free and I think he's got a normal hip examination. To complete my examination, I would like to, so don't say joint above and below, it just sounds like you're just reading off a page. Yeah, so you just say what it says. I would like to perform a full neurovascular assessment of the lower limbs and examine the lumbar spine and the knees. Okay, knee. Same thing. Again, you still look, feel, move. But because these are lower limb joints, used for locomotion, you watch people standing, you watch people walking. So with the knee, you look, and what are you going to look for? Yeah, that's good. You're looking from the front, not from behind. You're looking for varus. Valgus. Valgus is away from the midline, varus is towards the midline. And then you ask them to walk. And you're going to see if they've got maybe an antalgic gait or if they've got a valgus thrust or something. You're unlikely to have anything too common. That's pretty much what you do standing. So you kind of look from behind, from the front, from the side. Again, you comment on any walking aids, any footwear modifications, any abnormal wear pattern on their shoes, and then you get the patient to sit down carefully on the side of the couch, and you ask them to just extend their knee. And what you're looking for is the tracking of the patella. And you're looking for a reverse J sign. So if you've got patella maltracking, which way does your patella dislocate? Lateral. Yeah, it goes out lateral. So if you've got patella maltracking, your patella's be wanting to pull towards the lateral side, and it's more common in women because you've got a higher Q angle because of the angle of your hips to your knees, and so there's always this kind of constant pull where it's going to be wanting to pull your patella laterally. So physios, the first thing they always concentrate on when they've got any anterior knee pain, patella problems, anything, is vastus medialis obliquus, VMO strengthening. It's this muscle, and you'll notice it really obviously on anybody with a knee injury that this muscle just disappears completely. So what you're looking for is something called the revert or J sign, reverse J sign. So as they extend their knee into full extension, it just pops out towards that side. That's it. That's the standing bit, the sitting bit, and then you get the patient to lie down, and that's the bit of the knee examination that you probably know. So you want to feel, you you've already sort of had a look when the patient's standing up. And what are you going to want to feel for?
Fluid crevices.
Crevices.
Tendinous crevices, yeah, while you're doing some of your movements, you're going to be doing that, yeah. Yeah, and you look for infusion as well, so there's a couple of tests you can do for infusion. So, if you've got an effusion, if you've got a massive effusion, you can just empty the suprapatellar pouch of fluid, and then you can block the patella. And the reason, you can just feel it sort of floating on the fluid, and a click as it hits the femoral condyles. And that's for a massive effusion, or a large effusion. If you've got a smaller effusion, again, you want to empty out one side, empty the suprapatellar vertebra, keep your hand in that position. It's not quite like this, it's not that. And that's to stop the fluid from just shooting up into the suprapatellar pouch. The suprapatellar pouch is a massive space. You can just get the fluid up there, and you don't get your positive bulge touching the fluid. And the rheumatologists like this one as well, so you've probably been taught this one. Empty the fluid out one side, hand in the suprapatellar pouch, keep it empty, and you just brisk sweep across, and you'll just see a bulge on the other side, and the fluid just pops out because it's got nowhere else to go, because you've covered that space. And that's the most important bit. That's what you can tell the pouch covered. You can even pick up a smaller few. And then, what else? I mean, you can do other things. You can just look for symmetry, swelling, feel temperature, and stuff. And then what else do you want to test? You want to test for range of movement. We do range of movement. So range of movement again, actively with a knee. So you can ask them to lift their leg off the couch. And what you want to look for is the degree of extension, because a lot of people will have a bit of hyperextension. So if they've got hyperextension in their normal knee of 5 degrees, 10 degrees, and they've got none in the other knee, even though if you just examine that knee in isolation, it's normal. But we like to compare sizes of people, because people are different. So you can ask them to then just flex it up to how they're comfortable, and then you can just push it a little bit more. And that is your range of movement. The other thing, passively, is nice when the patient's lying down. You just take their heels and you ask them to just relax, pick their legs up, and you just see if their legs hyperextend, their knees hyperextend. So then what else do you need to assess in the knee, most importantly?
Collateral ligaments.
Yeah, you can do. I mean, we're not really covering
Collateral.
ACL.
ACL.
That's really part of
So ACL, PCL, lateral.
the lower limb neurological examination. But yeah, you could do it if you think that the patient's got a quadriceps rupture, a patellar tendon rupture. So yeah, so you want stability. You want to assess stability in terms of collaterals and cruciates. Lachman test. That's the most sensitive. It's the best way to test anterior instability. So ACL injury, the most sensitive test is a Lachman. That's better than doing an anterior draw. You do the anterior posterior draw anyway. The downsides of this are, if you've got small hands, or if the patient's got a massive leg, it's quite difficult. And then you might have to alternatively get your knee on the couch, which again, if you're short and you've got small hands, that's also difficult to do. And then you fix the patient's leg, big chunky thigh, or just put it around the thigh and use your hand. By the way, you've still only got one hand free to move their leg. So do the anterior draw as well. The important thing with the anterior draw is, I know this is a bit weird, teaching with pictures of myself on the screen, but it's kind of as a surrogate for demonstrating. So when you're doing an anterior draw, you see it done lots of different ways, hands in different places. But the important thing is to take your thumbs and slide them either side of the patellar tendon up until you just touch the femoral condyles, and then bring your fingers just loosely behind, flat. And that gives you a nice idea, even if you've only got a subtle bit of anterior instability, anterior draw, you can actually feel it from your thumbs as you go. Same thing for posterior draw as well. And with the patient in this position, you can look from the side to look if they've got any posterior sag, which again is called PCL. Posterior draw posterior sagrum PCL rupture, it's going to fall backwards, tibia. ACL rupture, it's going to be unstable and full of fall. You can also ask the patient, with their knee in that same position, you just activate their quads. And as they activate their quads, you might see if you've got a posterior cruciate rupture, again, the tibia is just going to pull backwards. You can imagine just pulling on that tibia. It goes back because you don't have the normal restraint. And then you test varus and valgus stress. So you do this in 0 degrees, which is this, and you also do it in 30 degrees to just unlock them. Because otherwise you can use other structures apart from your collaterals trying to stabilise your knee, particularly with your tibial band. You can kind of cheat. Pivot shift test. You just need to know it, know what it is. You say, well, I would like to perform a pivot shift test if you think you've got any anterior instability or ACL rupture. And you're looking for your rotatory subluxation of the joint. This is not something you need to do with that. Just know what it's called. It's painful. Some people, even if you've got an ACL rupture, you can't do it because they guard against it. And you can only really demonstrate it nicely in an anaesthetised patient. So now, foot and ankle. You know, my slides have got slightly out of order. Okay, so foot and ankle. Any questions about knee? That make sense? Foot and ankle, again, look, feel, move. So what are you looking for from behind the patient? You just ask them to stand. What are you looking for in your ankles? What are you expecting to see? Symmetry, yeah, not always. You're looking for valgus, right? You get a little bit of valgus. It's actually slightly asymmetrical. You can see here, there's a little bit of valgus here. That's normal. And then what happens to that when you stand on tiptoes? They swing into varus. So that's normal. So if the patient can do a heel raise start, that's normal. If their heel's swinging, it's going to stick to what's normal for now. When it's done much foot and ankle. But you should have a few degrees of valgus when you're standing, and a few degrees of varus when you stand on tiptoes. So this is the one orthopedic use of the VNF. Common block test. It is a perfect size for it. And a couple of the deformities, common deformities or common foot problems that you could see are going to be pes planus or pes plana valgus, where people have got tib post insufficiency and midfoot collapse and they've got flat feet. Or pes cavus from Charcot-Marie tooth or other neurological conditions that can sometimes be one-sided and then maybe completely idiopathic. But this is just telling you, if you've got a patient and they're standing and you're looking at them standing on the floor, like in that first picture, and they don't have that valgus in their heels, they've got varus while they're standing on the floor, they've got a cavus foot, they've got a high arch. And what this tells you is that if you get them to stand on a book, so their big toe, and what we call their first ray, is off the side. So if it's the first ray, which is low, giving you that high arch, and driving that whole cavus foot, if you take that out of the equation by dropping off the side of your BNF, your heel should then go into valgus and look normal. That's basically it. So it depends about, don't worry too much about it, we'll talk about this for hours. But as a shoulder surgeon, that's pretty much right. So again, same approach. Look, walk, and then you're going to be commenting on if they've got pes planus, pes cavus. That's probably what you'll see. Do the heel raise and the common block test. You don't have to do that. It's just so you know what it is. Ask them to sit down, and again, same thing. Look, feel, move, special tests. Less special tests, but so you can feel around the ankle. Just do it in a systematic way. You start from bony points, start from malleolus, ask the patient, is this painful, is this painful? You feel the insertion of the Achilles, you can feel the insertion of the plantar fascia, you can move their toes and ask them how it feels. And then you can do in the foot and ankle, you do active and passive movements. So you do passive range of movement of the joints and do active or provocative movements of the muscles and the tendons. Because what you're wanting to check is the function of the tendons. So they're provocative tests because if they've got tendinitis, tendinopathy, they cause pain. So the ankle, foot and ankle, passive range of movement. You look at the ankle joint, subtalar joint, which I seem to have missed off my slide, mid-tarsal joint, which is the show part joint, tarsal metatarsal joint, and really you just examine the first one. You can examine the big toe range of movement in your first MTPJ, and you can examine the lesser toes if they've got the lesser toe deformities. The provocative test you're going to do is tibialis anterior, tibialis posterior, peroneus brevis. So this one, anyone know what that muscle is? What's that muscle I'm testing? So, plantar flexion and inversion. Where are my fingers? Yeah, they're behind the medial malleus, and you can see the tip post standing out. So that's why you do plantar flexion and inversion. Does that make sense?
Which muscle was it? Which muscle?
Tibialis posterior. That make sense? No? Yeah, it should do. It just runs behind the medial malleus. Your peroneal muscles run behind your lateral malleus, peroneus longus and brevis. And tibialis anterior is that big fat muscle. You can kind of see it on there, even though she shouldn't be contracting it that much. Preferentially, you're going to be contracting tib post. Silver skills test. All that means is, it's a great word because it has an F and a V. And it's one of those little dot things. What you're doing is you're checking the range of ankle movement with the knee in extension and the knee flexed. So what's the difference going to be with the knee in extension and the knee flexed? So if you try and dorsiflex your ankle with your knee in extension, and you get not much, a few degrees, maybe it's just neutral. As soon as you bend your knee, you get a lot more. Why is that? It's like a simple, just physical reason. So what must that be? Something is less tight if you bend your knee. No, your Achilles is the same. Your Achilles tendon is the same, and so this is why it's useful.
Gastric news?
Gastric nemus. Yeah, so gastrocs. All you're doing is you're just taking the tension off your gastrocs. So if you've got tight gastrocs, when you do that, you bend your knee, and you do it, it won't make any difference. So that's silver Scots test. And you're just trying to differentiate between tight gastrocs and tight Achilles, pretty much. Does that make sense? Well, that took me years to work out. Common things you might see in foot and ankle. Pes valgus, where you've got flat feet, collapsed medial arches, too many toes sign. Too many toes sign, anybody know that? So a patient standing, again that same thing where you're standing, keeping behind the patient, ask them to stand. And if their feet are collapsed out that way, you see too many toes. Out the lateral side, that's called the too many toes sign. Pes cavus, we've talked about briefly. And lesser toe deformities. So you might find the patient's got hammer toe, mallet toe, whatever. Just lesser toe deformities, claw toes. There's lots of different reasons why they have them. They can be just from tight footwear. I'm sure some of you have got lesser toe deformities from tight shoes. Or they can be underlying neurological reasons. Big toes, hallux valgus. That's common. The bunion, hallux rigidus with arthritis, very stiff toe. Diabetic feet. It's quite a common thing as well. Very common. And they can ultimately end up in a Charcot foot, where they have this kind of painless, destructive joint process. And they end up with completely misshapen, destroyed feet because they can't feel. They've got no feedback, they've got peripheral neuropathy. rheumatoid foot again. If you see a rheumatoid foot, it's likely to have multiple scars on it. Again, it might have some of those kind of characteristic findings of rheumatoids, like in the hands, but it's often, you say, a patient's got feet that have been operated on multiple times. Get enough? We can do spine quick. Again, spine, same thing. Look, feel, move. Checking range of movement, it's unlikely to be a cervical spine or a thoracic spine thing. It's just probably going to be a lumbar spine. So again, expose the patient, have a look from the side, from behind. You're looking at coronal alignment to see if they've got scoliosis. On the side, you're looking to see if they've got lordosis, kyphosis, and then feel. So you can actually feel down the spinous processes, and feel the paraspinal muscles to see if they're tight or if they're painful. And then you just ask them to do a few things. So you get a lot of information in the spine clinic if you just ask the patient to walk on their toes and then walk on their heels. So what is that going to tell you? If they can do that, and then they can do that. What does that tell you about their lumbar spine? Think neurology. So what two things is that telling you? What's ankle flexion? What's your nerve root?
It's healthy or four, isn't it?
Maybe a few different ones. Just check it. Just read it. And then with your heel walking. It's not completely clear that it's one. And if you want to test one, L5, a good one is just resisted dorsiflexion of the big toe. So that EHL is L5, and the first web space is L5. So if you do have a lung spine patient and got sciatica, you can just ask them to just raise the big toe against resistance and feel in the first web space. Feel. That's L5. Trendelenburg test, you've already done that. And rhombose, you could do rhombose, it really depends, and it's just unlikely to, you don't have to do that. Squatting as well, again, you're just testing myotomes, but again, it's something you're unlikely to do, particularly in a patient who you think you're going to find that they've got a problem with that myotome. So, when they're lying down, you do a complete neurological examination, and the only way you do it with them is by practicing and getting it quick. You give it by MRC grade, which just read it, make sure that you know it, and sensation, make sure that you know the kind of autonomous areas for each myotome, so you can just do one finger and touch it and test each myotome. Sorry, dermatome. And then provocative test, so you see the cyclic stretch test. So the other provocative test is femoral stretch test. So this is Schober's test. Anyone know what Schober's test is? It is called Schober's test, isn't it? I think it is, yeah.
See if you're bending from the hip or flexing the spine.
Yeah. It just measures lumbar flexion. And so you just make these 2 points between the posterior superior iliac spine and the second nipples. And then line, I think, 10 centimeters above, 5 below, and then you put a tape measure on, and you ask them to bend forwards, and you measure the difference. If they do it and there's no difference, you've got a stiff lumbar spine. Cyclic stretch test, again, it's the same thing. And a femoral stretch test is a slightly funny one. You're going to get them to go prone. You're going to stabilize their pelvis and lumbar spine with one hand. You don't have to do it with the leg straight, because the tension is not coming from the leg being straight over the knee. It's coming from you stretching the femoral nerve over the front, so you just, it's quite simple to do, but you just flex the knee up above the leg. And that's pretty much it in terms of lower limb examination, a bit of spinal examination. I think trying to go through upper limb examination as well in this dry format is really going to be a bit too much. We're happy to teach in clinics, come along and watch us examine stuff and examine patients. But unfortunately, there's just too many people. Even now that we've lost about 30%, there's still too many people to really go through it properly. Just remember these points. Introduce yourself to the patient. do not hurt the patient or the actor. Practice your closing statement. Because once you've got practice your opening, your closing, all you remember is look, feel, move, and you remember one's bit, as long as you're sensible about it. And you've got an approach to examining any kind of joint or limb or whatever. But it's just all about being sensible and having practice your routine. And that's how we pass exams. The MRCS exam is the same thing, you just practice the routine and you do it. And the FRCS, the exam, you just practice your routines. So you don't think about the routines, you just